This is the ultimate guide to rheumatoid factor, a protein your own immune system produces that, instead of protecting you, can turn against your body and attack your healthy tissue. Whether your doctor just ordered this blood test, you are staring at confusing lab results, or you have recently been diagnosed with rheumatoid arthritis, this video will break down everything you need to know. So let us start with the basics. Rheumatoid factor, or RF, is an antibody, but unlike the antibodies your body makes to fight off bacteria and viruses, rheumatoid factor targets something it should not, your own healthy cells. Specifically, it is an antibody that binds to the Fc portion of another antibody called immunoglobulin G. Think of it this way. Your immune system has soldiers, and those soldiers carry weapons designed to fight invaders. Rheumatoid factor is like a rogue soldier that mistakes your own troops for the enemy and starts attacking them. That friendly fire creates inflammation, and over time, it can cause serious damage, especially in your joints. Now here's something most people don't realize. Not all rheumatoid factor is bad. Scientists have actually identified two categories. The first is physiological rheumatoid factor, which is polyreactive and low affinity. This type actually plays a helpful role. It assists in clearing out immune complexes and spent antibodies, essentially helping to clean up after your immune system does its job. The second type is pathological rheumatoid factor, which is monoreactive and high affinity. This is the troublemaker. It locks onto targets aggressively and drives chronic inflammation. So rheumatoid factor itself isn't inherently harmful. It is when the balance tips toward that pathological high affinity version that problems begin. Most rheumatoid factor in your blood belongs to the immunoglobulin M class of immunoglobulins, which is what standard blood tests typically measure. But rheumatoid factor also comes in immunoglobulin G, immunoglobulin A, and in rare cases, even immunoglobulin E and immunoglobulin D varieties. This is actually one reason the test can be tricky to interpret, but we will get to that. Let's talk numbers. What does a normal rheumatoid factor level actually look like? Generally, a result below 14 international units per milliliter is considered normal. Some labs use a cutoff of 20 international units per milliliter, and for nephelometric testing, the threshold is below 60 units per milliliter. Anything above these values is considered elevated or positive. But here's the critical point. A positive rheumatoid factor test does not automatically mean you have rheumatoid arthritis, and a negative result does not mean you are in the clear. The sensitivity of rheumatoid factor for established rheumatoid arthritis is only about 60 to 70%, with a specificity of around 78%. That means up to 80% of people with rheumatoid arthritis will test positive, but roughly 20% of confirmed rheumatoid arthritis patients will have a completely normal rheumatoid factor result. And on the flip side, about 5% of people who do not have rheumatoid arthritis at all will still test positive. This is where age plays a fascinating role. Among healthy 50-year-olds, about 5% will have a positive RF. But by age 70, that number jumps to 10 to 25%, with no disease present whatsoever. So if you're over 65 and your RF comes back slightly elevated, it might mean absolutely nothing clinically. Context matters enormously. This brings us to one of the biggest debates in rheumatology, RF versus anti-CCP antibodies. Anti-CCP is significantly more specific for rheumatoid arthritis at about 96% compared to RF's 70 to 85%. Both tests have similar sensitivity around 66 to 69%, but when it comes to ruling in a diagnosis, anti-CCP is the superior test. The gold standard approach is to run both. A positive RF combined with a positive anti-CCP strongly indicates rheumatoid arthritis. A positive RF alone requires much more investigation. Now let's put this in a global perspective. As of 2020, an estimated 17.6 million people worldwide were living with rheumatoid arthritis. That's roughly 0.25% of the global population. In the United States, the prevalence is higher, affecting about 1% of the population, and the numbers are climbing. Researchers project that by 2050, 31.7 million people will have rheumatoid arthritis worldwide, an 80% increase in just 3 decades. Women are disproportionately affected, with a female-to-male prevalence ratio of about 2.45 to 1. The history of rheumatoid factor itself is worth knowing. In 1940, a Norwegian researcher named Erik Waller first described a hemagglutinating factor in the serum of rheumatoid arthritis patients. 9 years later, a scientist named Pike gave it the name we use today, rheumatoid factor. It was one of the first autoantibodies ever discovered, and even now, more than 80 years later, we still don't fully understand its exact role in driving disease. That's a humbling reminder of how complex the immune system truly is. Here is where things get really interesting. RF does not just matter for rheumatoid arthritis. Elevated levels have been associated with increased cancer risk, tumor recurrence, and reduced response to anti-tumor immunotherapies. During the COVID-19 pandemic, researchers found that RF-positive patients had dramatically worse outcomes. The rates of invasive mechanical ventilation and death were significantly higher in RF-positive COVID-19 patients compared to RF-negative ones, 70.6% versus 28.4% for ventilation, and 45.1% versus 18.6% for death. The odds ratio for critical COVID-19 in the presence of RF was 7.31. That is a striking connection that researchers are still working to fully explain. There is also the phenomenon of seroconversion. Many rheumatoid arthritis patients start out seronegative, meaning their RF test comes back normal. But over time, as the disease progresses, up to 80% will eventually test positive. So a single negative test early on does not rule out the possibility that RF levels will rise later. This is why rheumatologists often retest over time. For those already diagnosed, rheumatoid factor levels carry significant prognostic value. High levels are associated with more severe disease, progressive joint destruction, a higher tendency to develop complications outside the joints like rheumatoid nodules and lung disease, and even reduced life expectancy when organ damage occurs. Values above 400 international units per milliliter are most commonly seen in rheumatoid arthritis or Sjogren's syndrome, particularly when associated with vasculitis. And now, the cutting-edge developments. Recent research is transforming RF from just a diagnostic marker into a tool for personalized medicine. Studies show that high RF levels predict a reduced response to TNF inhibitors, one of the most commonly prescribed classes of biologic drugs. However, those same patients tend to respond better to rituximab, a therapy that targets B cells. This means your RF level could actually help your doctor choose the most effective treatment for you specifically. There is even emerging evidence that TNF inhibitors lacking the IgG1 Fc fragment, like certolizumab pegol, may work better in RF-positive patients by avoiding the formation of immune complexes that RF would otherwise attack. So what should you actually do with this information? If your doctor has ordered an RF test, understand that it is one piece of a much larger puzzle. A positive result warrants further investigation, not panic. A negative result does not guarantee you are free of autoimmune disease. The test works best when combined with anti-CCP antibodies, clinical examination, imaging, and your symptom history. Rheumatoid factor has come a long way since Erik Waller first spotted it in a blood sample 85 years ago. What started as a mysterious hemagglutinating factor is now helping guide personalized treatment decisions for millions of people. But perhaps the most important thing to remember is this: RF is not a diagnosis, it is a clue, and understanding what that clue means in context with the right medical guidance is what truly matters. If you found this helpful, consider subscribing for more deep dives into the science behind your health. And as always, discuss your specific results with your healthcare provider, because no video can replace personalized medical advice. If this helped make sense of a confusing blood test, hit that like button and subscribe, because understanding your own lab results is one of the most powerful tools you have in your own healthcare. I'll keep breaking down the science behind your health, so stick around and I'll see you in the next one.